Today I am going to discuss the thyroid neoplasm, its clinical representation, investigations, diagnosis, and the treatment. By and large, thyroid neoplasm, there are two types. One is the benign and second is the malignant. Benign thyroid neoplasm is the follicular adenoma. There is no such term as papillary adenoma. Papillary adenoma is basically a carcinoma. How it presents clinically: a lump in the neck, especially either in the right lobe or left lobe, or in the isthmus or the junctional nodule, which may be variable size from few centimeters to many centimeters. This nodule, clinically it is solid, may be symptomless, may produce symptoms on the hollow tube is the trachea or esophagus, which may be dysphagia or dyspnea. Clinically, it may be euthyroid, hypothyroid, or hyperthyroid. After clinical history and in the examination, you find this is a solitary nodule arising from either type of the lobe, maybe right side or left side. It is solid, it is mobile, it is well circumscribed, and it is not fixed to the underlying tissues or overlying muscles. No lymph node enlargement, means as deep cervical lymph nodes, and you can suspect it may be a adenoma or it may be a carcinoma. Difficult to differentiate clinically, is it benign or malignant. After the history and clinical examination, your diagnosis for the follicular adenoma is a solitary nodule, solid, either it is a euthyroid or hypothyroid. Regarding the investigations, the first investigation you should do is ultrasound. Ultrasound is very sensitive, very specific to differentiate this nodule is either solid or cystic. Ultrasound has features which may differentiate between the benign and the malignant nodule, but is not so important as a medical student to know it. The only thing you should know it is either a benign, or it is a well capsulated, or it is a multinodular goiter, or it is only a solitary nodule, it is a solid or cystic. If it turns out to be solid, the second investigation of choice is you send the sample for thyroid functions, because you also want to prove not only clinically but also this by investigation there should be evidence that you are dealing with a patient of a euthyroid, hypothyroid or hyperthyroid, and that is TFT, thyroid function test. You should advise to have a FT3, free thyroid hormones, FT3, FT4 and the TSH. This is a thyroid profile which you do in every patient who has got a thyroid problem with as a goiter. And then at the same time, if the investigation is available in the hospital and the investigation which has to the test of time is the FNAC, fine needle aspiration cytology. It is operator dependent. You send to a very competent cytopathologist who knows his or her job. FNAC is a very sensitive and the useful investigation in majority of the patients to know that this nodule is a benign or malignant. But this follicular adenoma, which is a benign tumor of the thyroid, is difficult to diagnose on cytopathology because it will only let you know is a follicular neoplasm, which may be adenoma or it may be carcinoma, because the cytology will unable to differentiate between the benign lesion and the malignant lesion regarding the follicular neoplasm. When the report comes follicular neoplasm, you have to tell to the patients it may be adenoma or it may be carcinoma. The incidence of the adenoma is maybe 70 to 80%, and the follicular carcinoma may be 20 to 30%. It is difficult to differentiate at this time to give you a clear-cut opinion that this nodule is a malignant or benign. So the treatment with this regard is the ipsilateral lobectomy and hysterectomy. Then you send for histopathology and the report will clarify if it is this nodule under the microscope section reveals is well capsulated, there is no vascular or capsular invasion. The diagnosis is follicular adenoma, which is the commonest benign tumor of the thyroid gland. So there is no need of second operation. That is the treatment of choice for the follicular adenoma is ipsilateral lobectomy and hysterectomy. If the facilities of the FNAC is not available in the town, in the district hospital, and you get a patient have a solid nodule, the treatment of choice is lobectomy and hysterectomy, and then send the tissue diagnosis to the pathology department for the ultimate diagnosis. It may be carcinoma of the thyroid, follicular carcinoma of the thyroid, or it may be a follicular adenoma. After the histology has come and confirmed the diagnosis of follicular adenoma, you should discharge the patient on thyroxine, that is 50 to 75 microgram per day. The reason of prescribing the thyroxine is to prevent the compensatory hypertrophy of the contralateral lobe that may take time for 5 to 7 years, and the patient will come back the patient with the presentation as you have done the lobectomy on the right side, and after 5 or 7 years the opposite lobe found enlarged. For that reason, the dose of thyroxine should be minimum just to maintain the level of the TSH to prevent the hypertrophy of the contralateral lobe. That is the treatment of follicular adenoma, which present as the solitary nodule. Now we'll pass on to the malignant tumor of the thyroid. The carcinoma of the thyroid is the most common malignancy among the endocrine glands. The types of cancer of the thyroid which is most common in 75 to 80% of the cases is papillary carcinoma. Second is the follicular carcinoma of the thyroid. Then the medullary carcinoma of the thyroid, anaplastic or undifferentiated or poorly differentiated carcinoma. Then comes the non-Hodgkin lymphoma, and one of the variety of follicular carcinoma is also the Hurthle cell carcinoma. And the last or the least is the metastatic deposits in the thyroid lobe, which may be from the leukemic deposits or the carcinoma of the trachea, which can involve the thyroid gland, or carcinoma of the larynx. The well-differentiated carcinomas are papillary, follicular, or the Hurthle cell carcinoma, which is size of the cell is a bigger one. Hurthle cell carcinoma is also a variety of the follicular carcinoma of the thyroid. We will first discuss about the well-differentiated carcinoma of the thyroid, which comprises the papillary and the follicular and the Hurthle cell carcinoma of the thyroid, which is a subvariety of follicular carcinoma of the thyroid. The clinical presentation of the cancer of the thyroid presents as a solitary nodule in the thyroid gland, maybe right lobe, left lobe, or a junctional nodule. It can present as a multinodular goiter like anaplastic carcinoma of the thyroid, or multifocal papillary carcinoma of the thyroid, or a medullary carcinoma of the thyroid. It can present as the bilateral multifocal. Number two, it can present with solitary nodule or nodular goiter with metastatic disease in the deep cervical lymph nodes. You find one or two lymph nodes, L2 or an L3 or L4, found enlarged with one nodule in the ipsilateral lobe of the thyroid. That is the second presentation. The third presentation may be that you find a patient who has got large deep cervical lymph nodes with no clinically or radiologically palpable nodule in the thyroid gland. It presents as metastatic deposit in the cervical lymph nodes, while clinically you don't find any nodule in the thyroid gland. It's difficult to say it is a cancer of the thyroid or not. The only way you can rule it out by getting ultrasound of the neck, which is negative. Even sometimes the thyroid scan is negative. The nodule in the thyroid gland is so small, that is less than 1 centimeter and difficult to be picked up by the sono or by the scan, because you find this is normal. The only way to rule it out is you do the lymph node biopsy, thinking about it may be tuberculosis or lymphoma, and then later on you find the report comes out to be metastatic cancer of the thyroid. So that is the another presentation is the patient present with pathological fracture of the neck of the femur or a saccharin deposits in the brain or in the spine, and when you look at the neck you find there is a nodule in the thyroid, and that shows this is a case of follicular carcinoma of the thyroid, which is very notorious for hematogenous spread in the lungs, in the bones, and in the brain. So there are various clinical presentations of the cancer of the thyroid as a salty nodule, multinodular goiter, nodule with metastasis in these deep cervical lymph nodes, or present as the cervical lymph node metastasis while the parameter is too small to be picked up either clinically or radiologically. And the other presentation is that patient has got a pathological fractures and the orthopedic surgeon fix up and find the tissue is very friable, and they send for histopathology and turns out to be a carcinoma of the thyroid, that is a secondary deposit in the bone. And later on they look at the neck and they found there is a nodule in the thyroid. I think that is the reason the secondary has gone into the bone by the hematogenous spread, and the notorious cancer of the thyroid, which is notorious for the hematogenous spread to have a secondary deposits in the spine or bones, long bones, is the follicular carcinoma of thyroid or the Hurther cell carcinoma of the thyroid. The other clinical presentation is a hard lump in the neck involving the right or left lobe, this nodule is very hard, fixed to the underlying tissue or overlying staph muscles. Along with there is a pressure on the trachea or infiltration in the trachea, which may cause stridor as the tumor has invaded the trachea, or it may cause dysphagia because tumor has invaded the other hollow tube, that is esophagus, which lies behind the trachea. And that is a feature you can see in the patient who have got a papillary carcinoma of thyroid or anaplastic or the medullary carcinoma of the thyroid. These are the tubes which are more likely to be involved in these cancers of the thyroid. One should be very careful. The tumor is very aggressive. That is why it has got the extra thyroidal spread. And the commonest tumor which has got the extra thyroidal spread is papillary carcinoma, medullary carcinoma, anaplastic, or the undifferentiated carcinoma of the thyroid. In addition to that, the patient may complain of hoarseness of voice. So when a patient has got a lump, three things very important to ask: any history of dysphagia, stridor, or a change in the voice, hoarseness of voice. The most important symptom, they are pressure symptoms on the trachea or esophagus, or is there an infiltration of the tumor to involve the recurrent nerve on the same side. That presents with the hoarseness of voice. These are the commonest clinical presentations of the cancer of the thyroid. Once you have clinically made the diagnosis that it is a solitary nodule, difficult to differentiate between the benign or malignant, that is one possibility. Sometimes there is a circumstantial evidence clinically and also on the history. There is a hoarseness of voice, there is a difficulty in breathing, there is a difficulty in swallowing. Sometimes shows that the trachea is shifted, or there is also enlargement of the lymph nodes. So this, all these physical signs along with the symptoms are very suggestive of cancer of the thyroid. The tumor may present as just a solitary nodule to present advanced locally and as well as regionally into the deep cervical lymph nodes. Local spread is a very aggressive spread which involves the trachea and the esophagus and the recurrent nerve. Regarding the history and clinical examination, the first investigation as told is the ultrasound. It gives you a lot of information about the nodule in the thyroid gland, and also you can see the enlarged lymph nodes, which group is enlarged. Usually the lymphatic drainage of the thyroid gland is into the cervical lymph nodes, that is from L2 to L5. Clinically and radiologically you may find the L6 or even the L7 lymph nodes on CT scan or MRI. It depends upon the extent of the spread of the tumor in the lymph nodes. So after the ultrasound, then the second investigation in the blood sample is thyroid function test, and you do the FNAC. FNAC will let you know which type of the cancer. One cancer cannot be picked up, and that is the follicular carcinoma of the thyroid. Papillary, 50% of cases medically can be picked up, and the anaplastic and difficulty sometimes lies with the lymphoma to pick up by FNAC. By and large, FNAC is a very good investigation for cancer of the thyroid, and the commonest cancer of the thyroid is the papillary carcinoma, which is present in 85% of the cases. Second common cancer is the follicular carcinoma, difficult to pick up either clinically or radiologically or cytologically. The only time tested thing is that on that side, whichever the lobe has got a nodule, you do the lobectomy, and then the histopathology will let you know there is a vascular invasion or the capsular invasion, which is good enough to diagnose a case of follicular carcinoma of thyroid, or the type of the large cells is Hurth cell carcinoma, which is also a subvariety of the follicular carcinoma of the thyroid. Once the diagnosis is made and the lymph nodes they are clinically involved or not, I think the investigation of choice is this CT scan. That will let you know the extent of spread of the tumor, primary tumor of the thyroid, and also to look for the secondary deposits in the cervical lymph nodes. Remember, one thing which is most important is the cancer of the thyroid usually occurs in the nodular goiter, not in the diffuse goiter. The papillary carcinoma is the most commonest cancer of the thyroid, which is present in 85% of the cases. No age is immune to papillary, occur in the younger age and teenage group. Even in the children below the age of 20, this papillary cancer is very common. And the above the age of 50, this carcinoma of the thyroid papillary is very aggressive. So commonest is below the age of 20, usually or above the age of 50, the tumor is very aggressive. This tumor is usually occurring in teenage group, in medical students or in 20s and 30s. This is maybe unifocal, it may be multifocal, it may be multicentric within the one lobe, or it may be multifocal involved with the other lobe also. It grows slowly. The prognosis of this cancer is not bad in a younger age group. This tumor biologically is very aggressive when you cross 50. It is mainly spread by two routes. One is the local spread, that is the direct spread, to involve the overlying muscle or underlying tissues, the tubes, trachea, esophagus, or the recurrent laryngeal nerve. That is a direct spread, or you can say the spread which is extra thyroidal spread into the surrounding tissues. The second spread, which is the notorious spread for the papillary, is in the regional lymph nodes. As you know, the lymphatic drainage of the thyroid gland is from L to L5. Usually, which is clinically, these lymph nodes are palpable if they are enlarged. Regarding the treatment, what we will do? FNC is very classical, you can pick up, but usually the follicular variant of papillary carcinoma of the thyroid is difficult to pick up. That is another problem, which is a new emergent variety of classic in the papillary carcinoma of the thyroid, follicular variant of papillary carcinoma. That is sometimes difficult to diagnose on cytology, and that presents as either follicular cells or atypical cells of unknown origin. So where you can't do the total thyroidectomy, you do the lobectomy and hysterectomy, and then they found this is a carcinoma, then you have to do the second operation doing the completion thyroidectomy, and that is the follicular variant of the papillary carcinoma. If the nodule is solitary and the size of the nodule is more than 1 centimeter, the treatment of choice is total thyroidectomy with predictable safety of both parathyroids and the recurrent and the external laryngeal nervi. If the tumor of the papillary carcinoma having a cervical metastasis, the treatment is the total thyroidectomy, irrespective of primary size of the tumor, with modified blocked section of the neck. When say modified blocked section of the neck, means you can roll all the lymph nodes in the apsilateral half of the neck, both in the anterior and the posterior triangle, containing the lymph nodes from L2 to L5, saving the common carotid, the external carotid, the internal carotid, the valgus, phrenic nerve, of course the brachial plexus. In the modified blocked section type 1, we save the spinal accessory nerve which supplies to the trapezius, because if you cut this nerve, there's a dysfunction of the shoulder, and there is a wasting of the trapezius. So in modified blocked section type 1, you can sacrifice the sternomastoid internal jugular vein along with the blocked section, but you save the spinal accessory nerve, because the tumor burden is too much, so you can't save the sternomastoid and the internal jugular vein. So this type of modified blocked section is type 1. If you save two structures, you save the spinal accessory and as well as the internal jugular vein. So this is called modified blocked section type 2. If you save all the three structures, the sternomastoid, the internal jugular vein and the spinal accessory nerve, this is called the modified blocked section type 3, or we can call it as a conservative blocked section. So conserve all the three structures, that is the internal jugular vein, the sternomastoid and the spinal accessory nerve. It is also known as the functional blocked section. You just roll out, or you just take off all the lymph nodes like a carpet from the perivertebral fascia, both in the anterior and the posterior triangle of neck, as you preserve the sternomastoid, the internal jugular and the spinal accessory nerve. In classical blocked section of neck, the tumor burden is too much and it's difficult to save any structure. So in classical blocked section of neck, you take off the lymph nodes and lymphatic tissues from L2 to L5 or L6, along with the sternomastoid, internal jugular vein and the spinal accessory nerve. This is called classical blocked section, where you sacrifice all the three structures. If you save one structure, it's called modified type 1. If you save two structure out of three, it's called modified type 2. And if you save all three structures, this is called as modified type 3 or conservative or functional blocked section. But if you sacrifice all the three structures, then it is called classical blocked section of neck, which is done not only the cancer of the thyroid, you can also do for the carcinoma of the parotid, cancer of the tongue or the oral cavity, because these tumors are very aggressive. The tumor burden in the lymph nodes is very high, so naturally you have to do the classical blocked section because of the tumor burden. The treatment of the follicular, so the treatment of the papillary carcinoma of the thyroid is from total thyroidectomy alone to total thyroidectomy plus the blocked section of neck, and followed by I-131 ablation therapy, which is very important in well-differentiated carcinoma of the thyroid, which may be papillary, or next time I will tell you, the follicular carcinoma. I-131 ablation is very important. It will completely eradicate the thyroid tissue in the neck after doing total thyroidectomy, or if the needs of blocked section, doing total thyroidectomy plus the radical neck dissection, followed by the I-131 ablation therapy. Don't give thyroxine for 3 weeks. Let the TSH should go up. It will swell up any thyroid tissue anywhere in the body, and then the TSH should go above 30. Normal is between 2 to 5. It should be 6-7 times more than the normal. So any thyroid tissue present anywhere as a secondary deposits or a primary thyroid tissue will swell up. And then you get the, after the elapse of 3 weeks, not to give thyroxine, and then you get TSH. and then you are advised to have a total body scan. It will pick up any thyroid tissue which is present in the thyroid bed or anywhere in the body. After that total body scan, you advise the patient to come back and receive the radioactive iodine I-121, I-131 or radioactive iodine. That is the ablative dose to destroy any thyroid tissue either in the thyroid bed or anywhere in the neck. So it means the body is no thyroid now at all. So you will find the thyroglobulin will be very much low rather than not, because thyroglobulin is formed by the thyroid tissue. So if there is no thyroid tissue and there is no thyroglobulin, it is very easy to follow up of these patients, because you can call back after 4 months to get this on, and you will find the thyroglobulin, there is no thyroglobulin because there is no thyroid tissue. So it means that is this total thyroidectomy followed by I-131 ablation therapy is very appropriate treatment in a papillary carcinoma of thyroid or a follicular for follow-up. So the thyroglobulin will act as a tumor marker for the cancer of the thyroid after doing the complete treatment of well-differentiated thyroid cancer, that is total thyroidectomy followed by I-131 ablation therapy, followed by you can advise to give a full dose of thyroxine. The usual adult dose of thyroxine is 125 microgram per day. There is no need to suppress the TSH in papillary carcinoma, which was the old theory. They say because if you suppress the TSH, as the papillary carcinoma is TSH dependent, but you don't get the advantage to suppress the tumor, but you can get the disadvantage of overdose of thyroxine, and which is osteoporosis, fractures, and the cardiac complication like atrial fibrillation. So the dose should now in current practices is 125 microgram per day. Adult dose is enough when there is no thyroid gland in the body. So it is neither too much aggressive dose or not too low dose, so that it will maintain the TSH around about 2 or above 0.1. So that is all about the papillary carcinoma. The treatment vary from total thyroidectomy to total thyroidectomy plus the blocked section of neck, followed by, no matter the tumor is only confined to thyroid lobe or to the metastatic disease in the lymph nodes, you have to give the ablative dose of radioactive iodine after the completion of the operation. Whatsoever the operation is, either only the total thyroidectomy or thyroidectomy plus the radical neck dissection, which is called compound resection. The second common cancer is follicular carcinoma of thyroid. It is a unifocal. It occurs in about 40 to 50 years of age. Cancer, thyroid cancer is more common in the females, but when it occurs in 40s and 50s, in the male, the incidence of the cancer is 40%. Regarding the follicular carcinoma, it presents as a nodule, enlargement of the lobe. It clinically looks as a euthyroid or hypothyroid. If you examine the lobe, it's just like a normal lobe which is enlarged. Predominantly spread by blood-borne metastasis. Lymphatic metastasis occur only in 7% of the cases, which is very rare, as compared to papillary carcinoma, which is spread predominantly by lymphatics. This follicular carcinoma is notorious for hematogenous spread. The tumor spread by the blood, by the veins, and the secondary can go to the lung, to the brain, to the spines, to the bones, anywhere. So this is a less more aggressive than the papillary carcinoma. It has a blood-bound metastasis. The second spread is a local spread, which is not so much common in follicular carcinoma because if you palpate them, it just looks like a normal thyroid tissue or the lobe which is enlarged and the texture is same as a normal thyroid gland texture. Difficult to diagnose clinically, radiologically, and cytologically. So what to do is do the total lobectomy and hysterectomy. If the biopsy shows the vascular invasion and the capsular invasion, then the treatment is you have to revise and you go back again and do the completion thyroidectomy because follicular carcinoma of thyroid cannot be picked up on the FNAC. So you have to explain to the patient prior to the operation that you may need another operation if it turns out to be a cancer because this type of cancer is not picked up by FNAC. The patient should be mentally prepared because the incidence of cancer may be 30%. That in 30% of the cases, you have to revise the operation, you have to go back in the neck and remove the opposite lobe to do the completion thyroidectomy. And of course, followed by I-131 because it's also a variety of well-differentiated carcinoma which is very super sensitive to I-131. So the primary has to remove as a total thyroidectomy and I-131 ablation therapy is done or is given to the patient after the completion of the operation, which may be total thyroidectomy or which may be, as you say, with the lymph node found enlarged as in case of Hurther cell carcinoma because this tumor spread both by lymphatics and as well as by the hematogenous spread. This Hurther cell carcinoma is an aggressive tumor as compared to follicular because this does not respond to radioactive iodine because it doesn't pick up the radioactive iodine. So when the tumor does not pick up the radioactive iodine, it will not be destroyed. So that is the drawback of the Hurther cell carcinoma, which is a subvariety of the follicular carcinoma. It tends to spread locally, regionally, and as well as hematogenously. Because it's spread by lymphatics, it can spread by blood-borne, but it is not sensitive to radioactive iodine. That is the drawback of this Hurther cell carcinoma. It is more aggressive as compared to the follicular carcinoma of the thyroid. If the patient has got a second deposit in the spines or in the brain, the scalp or the bones, it is only picked up when you deal with these second deposits and then they show this is a thyroid cancer or thyroid tissue. Then you go ahead and no operation less than total thyroidectomy is the answer. So you do total thyroidectomy and then total body scan and you give I-131 ablation therapy for the secondary deposits anywhere in the bones, lungs or brain. It will melt like a ice in front of the sun. That is the treatment of the follicular carcinoma of the thyroid. Next time we will discuss about the medullary or anaplastic.